With metabolic acidosis, you have a pH of less than 7.35. You have a bicarb that's less than 22 milliequivalents per liter. And you have a partial pressure of carbon dioxide that's either normal or low. If it's normal, it's uncompensated. If it's low, it's compensated. But we'll get to that later. So let's say that you have all these, everything falls into place for it to be metabolic acidosis. You have the low pH, you have the low bicarb, and you have either the normal or low carbon dioxide levels in the blood. Then you run an anion gap because you want to find the underlying cause of this metabolic acidosis. There's a lot to this, but let's just go through the algorithm. I'm trying to simplify this. So we have the major extracellular cation, which is sodium. And we subtract chloride and bicarbonate from that. That's sort of the two primary extracellular anions. If this number is greater than 10 to 12, we know we have an anion gap metabolic acidosis, and we can start narrowing down our diagnosis. If this is the case, we have extra acid that's added to the blood, and it could be 4 different causes. The causes are in a mnemonic called CULT, with K being ketoacidosis. This is caused by type 1 diabetes mellitus. This is where you're not making insulin. You have autoimmune disease that destroys the beta cells of the pancreas. So at this point, glucose levels skyrocket, but they can't get into the cells because there's zero insulin. So the body starts utilizing fat as fuel and spilling into ketones, and it just overwhelms the system because these ketone bodies are acidic. They donate protons to the blood. It's impossible to get this with like a ketogenic diet. This is where you have zero insulin. So that's one cause. Another is uremia. This is usually with kidney failure. So like the end-stage chronic kidney disease, where the body can no longer excrete waste. Typically the GFR, glomerular filtration rate, is less than 20, and it just cannot excrete waste. So it builds up in urea in the blood, and that's called uremia. And urea is the breakdown byproduct, getting rid of the nitrogenous base portion of amino acids and proteins. So the kidneys just can't get rid of that waste, and it builds up. This can cross the blood-brain barrier and cause neurological problems. Another is lactic acidosis, and this is probably the most common cause of anion gap metabolic acidosis. If you think about the whole cellular respiration system, you start with glycolysis, and if there's oxygen available, then pyruvic acid will move into the mitochondria and go through the Krebs cycle or citric acid cycle. So for some reason, if you're low on oxygen, maybe you have some kind of cardiogenic shock, like you're having a heart attack and you just can't get blood to the tissues, you don't have oxygen, and your muscle cells will have to generate ATP through glycolysis, and that builds up lactic acid. Any cause of low oxygen, it could be severe dehydration. You're just not kind of hypovolemic and not getting enough oxygen to the tissues. Another is clearance. So lactic acid's cleared by both the liver and the kidneys. So if you have any kind of liver problem or kidney problem, you can have a buildup of lactic acidosis. And another one is meds. So like propofol is one that can cause lactic acidosis. Another one that throws a wrench into the electron transport chain and causes some lactic acidosis is metformin, which is the first line medication for type 2 diabetes mellitus. And then the last one, T, is toxic ingestions. And there's another mnemonic called mud piles that you can learn if you want to learn all the individual toxic products. But for example, salicylates, that's in aspirin. If you have an overdose of that or something like that, that can cause an increase in acid in the blood. Ethylene glycol, if somebody, a child accidentally ingests antifreeze, and there's other ones too, but we're not going to go into that list because I want to kind of keep this simplified with CULT. All right, so that's if we have extra acid. It's called anion gap metabolic acidosis. What if we do this calculation for anion gap and it's less than 10 to 12, but we still have this metabolic acidosis going on? It is a non-anion gap metabolic acidosis. And there's only 2 causes this could be. And so if you have this, you immediately do a urine anion gap. And I'm not going to include the calculation for that one because I want to keep this somewhat simplified. But the two things it could be is diarrhea or renal tubular acidosis. So what's happening here with diarrhea, when you have diarrhea, you're losing a lot of bicarbonate because in our small intestine, we have a ton of bicarbonate to buffer that acidic chyme coming from the stomach. So if you're losing that, then you're losing a lot of bicarb from your body, and it's going to drop the bicarbonate. What's really, really important to know, because I know you're smart and you're asking this question, if the bicarb dropped, will that anion gap still be more than 10 to 12? Well, whenever the bicarb drops, so that's the primary loss of why we have this acidosis, chloride will actually come up to help keep that neutrality. So in other words, if we're losing bicarb from diarrhea, in response to that, our chlorine will go up. And so it'll meet that same electrical charge. And so we don't get that anion gap. I know it's kind of complicated. So I'll go over it one more time, but with renal tubular acidosis. With renal tubular acidosis, there's a type of renal tubular acidosis where the kidneys, there's necrosis of the kidney tubular cells that line our nephron, and they can't reabsorb bicarbonate in the proximal convoluted tubule where 80% of that reabsorption happens. We try to get back that bicarb because our body's typically trying to battle acid. And if the kidneys aren't functioning because they have renal tubular acidosis, our actual cells are dying in our nephrons, then we're not as efficient as bringing that bicarb back. So that's another place where our body's causing a decreased loss of bicarbonate. So in response to that, the chloride will rise up and make it a non-anion gap metabolic acidosis. So now that we have that down, let's go ahead and look at a vignette over here where we have I want to show you the normal values first, and then we'll look at the vignette. So we have normal being pH 7.35 to 7.45, sodium 135 to 145 milliequivalents per liter, potassium 3.5 to 5 milliequivalents per liter. That's why we don't even include potassium in the anion gap calculation. It's so negligible. You know, most of our potassium is intracellular, so they don't even fool with throwing that in the equation, thank goodness. And then bicarbonate typically is between 22 and 28 milliequivalents per liter. Some sources say 22 to 26, but in that range. Chloride should be 95 to 105 milliequivalents per liter. Partial pressure of carbon dioxide should be 33 to 45 milliequivalents per liter. So here's the case study. We have a patient, their pH is 7.2. So we know it's either got to be metabolic acidosis or it's got to be respiratory acidosis. The numbers will tell us. A lot of times they'll do arterial blood gas, maybe take it from the radial artery, and they get these values. So we determine we have a acidosis, and our values are sodium is 145 milliequivalents per liter, chlorine is 114, and bicarb is 9. So our pH is low, so is our bicarb, so that tells us this is a metabolic acidosis. And then partial pressure of carbon dioxide is 22, and that's low. We'll talk about why that's low after this. So we decide we have a metabolic acidosis. So the first step we do is we calculate an anion gap. The anion gap is sodium. We don't worry about potassium because it's so small. Sodium minus chlorine minus bicarb. And so we end up with 22. Is 22 more than 10 to 12? Yes. So now we know we have an anion gap metabolic acidosis, and we start looking at CULT because that's our causes, and we want to get to the root cause because that's how you treat it. You find the root cause and you treat the root cause, and hopefully it will restore normal pH. So we look into it a little bit further, and we find out that this patient has a GFR, a glomerular filtration rate of less than 20. A normal GFR is 90 to 120. This is extreme kidney failure. So then we would need to really, it could be a couple of things. It could be uremia because they're not able to excrete the waste. It could be lactic acidosis because the kidneys aren't able to excrete the lactic acid. So either way, we're kind of narrowing it down. So what's going on here with the partial pressure of carbon dioxide? It's normally 33 to 45 millimeters of mercury. That's how you measure pressure. So if it's 22, what the lungs are trying to do is they're trying to compensate for this pH. So the more carbon dioxide you breathe out, the more acid you're getting out because it makes carbonic acid. So the kidney, the lungs are really trying to help us out. We have this end-stage kidney failure, and the lungs are trying to help balance that acidosis, and it's failing. So this will be an uncompensated metabolic acidosis, because even though the lungs are trying their hardest to help, they're trying to excrete as much carbon dioxide as possible, we're still at 7.2. That's still below 7.5. If this number was 7.37, it would be compensated metabolic acidosis, but it's not. So I know metabolic acidosis has a lot to it, but hopefully this video will help. If not, just watch it a couple times till you get it. Ask questions in the comments, and I'll see you in the next video.